Good evening, everybody, and welcome to this webinar on tele-ophthalmology or telemedicine. As the entire world is passing through the crisis of COVID-19, I think everyone is looking at keeping in touch with patients to answer their queries, to counsel them, to give them advice in the best way that is possible under the present circumstances. So, leaving apart what we were thinking, I think the Medical Council of India has come around with guidelines which have superseded the previous guideline. There were earlier judgments also against the telemedicine, doing of telemedicine, etc. So now it's pretty much a legal way of looking at telemedicine. So we are wanting to just keep the members abreast as to what the telemedicine scenario is, and there are a lot of speakers that we have whom we are wanting to get onto this panel. So to start with, I'll just give you a brief intro as to what exactly the telemedicine we are looking at and what AIOS has actually done. Are my slides visible?
Yes.
Yes.
Yeah. Okay. Yes. Fine. So let's start with the practical guidelines that have been issued by Medical Council of India, as also what AIOS has said about it. And before we start, I would wish to say that hope all the members of All India Ophthalmological Society and their relatives, friends, and community are safe. And we hope and pray that we live through this crisis and come out victorious against the COVID-19 infection that is there. Now, I have with us a panel of speakers. To start with, I'll be talking about the AIOS guidelines for telemedicine in ophthalmology, followed by Professor Amita Sharma, who has been very, very active as Secretary of All India Ophthalmological Society in taking up all the issues and arranging lots and lots of things that AIOS is trying to do. She'll be talking about generally telemedicine, as to what exactly telemedicine and ophthalmology is, and as to what other countries are doing. Then I have with me Dr. Ritika Sachdev, who is Director at the Center for Sight Group of Eye Hospitals, and she'll be talking about the various platforms that are available for tele-ophthalmology or telemedicine, and whether this crisis offers somebody an opportunity. Then we have the next talk that will be by Dr. Praveen Krishna, whom we all know as a fantastic corneal surgeon, and he's director at the Cornea Institute for the LV Prasad, and he'll be talking about the experience of LVP. They're starting telemedicine in LVP. This will be followed by a talk by Dr. Sudhir, who is a senior consultant again in cornea refractive, and he's also a consultant in charge for the EMR of Shankar Netralaya. And he'll be talking about the teleconsult experience that has been taken over, that Shankar Netralaya is practicing as things stand today. And then we'll have Dr. Garewal, who is the Managing Director of Garewal Eye Institute, somebody who's very astute with the future and technology. And he'll be talking about future of telemedicine and ophthalmology. We have three distinguished panelists with us, starting with Dr. Debashish, whom we all know, the past president of All India Ophthalmological Society, a very, very kind and a nice human being, and also somebody who has brought about a great revolution as regards ophthalmology in the entire state of West Bengal. He'll be talking or be a panelist and also share a few slides about the experience of what Disha has been doing. And then we have Professor Rajesh Sinha, who is really doing a commendable job as the treasurer of All India Ophthalmological Society, and he will be a part of the panel discussion. And then we have the dynamic Dr. Raj Shekhar, who is the president of Karnataka Ophthalmic Society, and he's been doing successful telemedicine, etc., as in the Shekhar Eye Hospital. So he'll be talking about his experience and answering questions from all of you. So let's just start with the first talk as to what exactly tele-ophthalmology stands today. And I'll just wish to give you an introduction as to where things are. Maybe a year ago, we were all frightened out of giving consults on a phone or telemedicine, because there was a court case that was where the doctor was held guilty for not examining a patient and giving away consult on the telephone. And also there was a warning that was issued by KMC to doctors against any online consultation. Much water has flown since May 14, 2019, when this KMC warning came. And today, and I think there is a sea change and people have realized that telemedicine is going to be a way of life. Now, what exactly is the reason as to why we are looking at telemedicine is that there is an enormous scarcity of doctors today, and there is only one doctor per 10,189 people in India. And because of the lockdown, because of the curfew situation, etc., and sealing, there are going to be problems which people will have, and we need to answer those problems. Now, what are the guidelines that MCI has issued? So MCI, in supersession of its previous ethics conduct, etc., on 25th of March has given for particular amendments and as to how an ophthalmologist or a registered medical practitioner should do telemedicine or teleophthalmology. So when you're looking at telemedicine practice guidelines issued by the MCI, any registered medical practitioner is entitled to provide telemedicine consultation from any part of India. That means that it is not necessary that you can do a telemedicine only to patients within your state. Now, the second thing is that the RMP wherever I'm using is for registered medical practitioner. Using telemedicine should uphold the same professional and ethical norms and standards as is applicable to traditional in-person care within the intrinsic limitations of telemedicine. That means that they also realize that there will be limitations of telemedicines, but the standards of ethical norms have to be the same as you would if you are seeing a patient face to face. Now, practitioners shall also exercise proper discretion and not compromise on the quality of care. They should be convinced that telemedicine is in the patient's interest after taking a holistic view of the situation. That means that there is a lot of responsibility on the practitioner to actually realize as to whether what he or she is doing is good for the patient and in the best interest of the patient. Now, telemedicine, there are various tools and all of them stand approved, whether it be the telephone, whether it be video devices, LAN, WAN, internet, mobile, landline phones, even chat platforms like WhatsApp, Facebook Messenger, etc., mobile app, internet-based digital platform, and you can also have data transmission like Skype, email, fax, etc. So irrespective of the tool of communication used, core principles of telemedicine practice would remain the same. Now, let us see as to what are the guidelines for doing the practice of telemedicine. The first guideline that has been issued is that telemedicine consultation should not be anonymous. That means that both the patient and the RMP need to know each other's identity. It should not be a proxy or an anonymous telemedicine consult. Now, you have to verify and confirm the identity of the patient by name, age, address, email ID, phone, registered, whatever methodology it is, but that needs to be identified and preferably ask for a soft copy of the ID proof when giving an appointment. Ensure that there is a mechanism verification of credentials and contact details. So that is something that the onus is on you and you need to verify these. Now, what is also important is that when you are issuing a prescription after telemedicine consult, the exact age and sex and name of the patient with proof needs to be mentioned on the prescription. And in case the patient is a minor, after confirming the age, the teleconsult along with an adult whose identity needs to be ascertained has to be there. That means that who is the legal guardian of that minor, or even in case that a person is infirm to give a consent. Now, what is important is that you have to begin the consultation by informing the patient about your name, qualifications, and your registration number. So that has to be displayed on the teleconsult, that who you are and whether you are a registered medical practitioner or not. Now, the same principles of medical ethics, including professional norms for protected patient privacy and confidentiality as per the Medical Council of India Act, shall be binding and must be upheld and practiced. That is something very, very important. Now, let's come to the consent. There are two types of consents. One is an implied consent and the other is an explicit consent. So whenever the initiation of telemedicine consult is from the patient, it automatically is an implied consent for all teleconsults. But in case the caregiver is initiating a teleconsult, then you have to take an explicit consent, and this explicit consent should be recorded in any form, whether it be an email, text or audio or a video message, and the patient states the intent on phone or on video to the RMP in simple words. So that means the patient should state in his or her own language as to what is the intent, and you should record this in the patient's record. Now, this is the informed consent for telemedicine services, which has been circulated by AIOS, and we would, in case anybody wants, you can we can circulate it again to you. So this is the consent that needs to be taken, which is a explicit consent in case you are initiating a teleconsult. Now, when you have started the teleconsult, how should you manage a teleconsultation? All efforts to be made to gather sufficient medical information. That means whatever best medical information you can gather, you should get it. And if appropriately managed via telemedicine based on type of consultation, then only proceed with a professional judgment. That means that you should be reasonably sure or sure as to what you are going to say or suggest to the patient does not cause any harm to the patient. So telemedicine can broadly be described into three parts. First is, it can be used for giving health education as would be appropriate in the case. The second could be giving counseling related to a specific clinical condition. That means somebody has been operated, he wants to ask, can I take a head bath? Can I splash water in my eyes, etc., etc. And the final thing is that it can be used for prescribing medicines, eye drops, etc. that would be required. Now, they have also in the MCI tried to differentiate between a first consult and a consultation which is a follow-up consultation. In the first consult, it should be you should be very, very sure, because there is a limitation of the understanding as to what the patient is undergoing or what the patient has. So it is better to have a first consultation by video and whatever best you can see. The follow-up consultations of a patient, if you have already seen a patient, you should have the records preferably from your EMR system of the patient, and therefore you can give a better and a comprehensive management to the patient. So that is the difference between a first consult and a follow-up consult, because you are more knowledgeable in a follow-up consult. Now, the documentation of the consultation is also very, very important, and you need to maintain digital trail or documentation of the consultation. So whatever you have given, you should have a documentation as to what you have given, so you can easily record what you are saying and what the patient is saying. And the log or the record of the telemedicine interaction, phone logs, email records, a picture of WhatsApp, etc., should be there and preferably kept in your record. And these, in case a patient is sending any reports, documents, images, etc., whether digital or non-digital, that should also be appended to the records. Now, the prescription records are also required as they are required for in-person consultation. That means that what you are prescribing to the patient, as you keep in your EMR the record of that, the same should be kept for tele-ophthalmology or telemedicine. And this should also include the payment details and the invoices raised. That means that if you are taking a payment from the patient, the invoice and the payment details should be there. Now, when you are looking at the next step, which is prescribing medicines, it is at the professional discretion of the registered medical practitioner and entails the same professional accountability as traditional in-person consult. If the medical condition requires particular protocol to diagnose and prescribe, just like in-person consult, then the same principles have to be applicable. That means that you cannot be lax vis-a-vis making a consultation and the management and the treatment that you are going. You should be having the same principles as you would if you were seeing the patient. Now, the prescription of the medicines should be only relevant, and enough information and prescribed medicines are in the best interest of the patient. But one thing is very, very important, that prescribing medicines without making an appropriate and a provisional diagnosis which can harm the patient will only amount to professional misconduct. So there are these barbs and these needles that will be there on the way for you to take care as to what exactly would be prescribed by you, that is there. Now, the professional conduct and etiquette and ethics are entirely the same as they are for in-person consultation that you give for a patient, and protecting the patient privacy and confidentiality is also very, very important. It is only in case there is some hacking of your software, etc., and you can show that you have not given it deliberately and you have not exposed the privacy and confidentiality, then you can be excused. So in case there is a hacking of your software or something, there is some ransomware, etc., you should file an FIR, and you should be safe that this compromisation is because of a technology breach and not because you have handed over the patient privacy and confidentiality to somebody else. Now let's come to the point of fee for telemedicine consultation. You can have a consult fee as regards what you want to charge in the OPD. You can do it free as some people are doing, or you can invoice to the same level as you would do in your OPD, and you could also fix a time. That means for the teleconsult, a 10 minutes or a 15 minutes time equivalent to your OPD fees, etc. And therefore, if a person wants to extend, the fee will need to be paid, which can be more. Now, when you're looking at a teleconsult for emergency situations, this is to provide in-person care at the earliest. That means this is a stopgap measurement between your giving some first aid or telling a patient to take certain critical steps, which could be life-saving or sight-saving, and advising first aid and counseling the patient. But this is only to facilitate a referral. That means that till such time that the patient reaches the hospital for an emergency consult, this is a stopgap arrangement, and patient must be advised for an in-person interaction with an ophthalmologist at the very earliest. Now, when you are looking at teleconsultation, I'll just wish to give you some pearls as to what it is. This is, as I already said, you should identify yourself. This needs to be done, your hospital name, etc., your medical registration. Doctor can choose the medium of teleconsultation. This again is up to you as to how you want to do teleconsultation. The other important thing is, please keep the language formal. There should be no slang, no intimate language, etc., like hot, killer, awesome, etc., etc. So you should look at these type of informal languages that is there. And there should be no proxy consultation. I am highlighting it again. The only exception if the caregiver is deemed to be authorized on behalf of a minor or an incapacitated patient, and the caregiver's identity and authorization has been checked by you. Now, other important pearl is that you should terminate the teleconsult anytime you feel that the patient needs a physical consultation. That means that you're going ahead with a teleconsultation and you feel that no, you could err on giving the medical treatment, then you should say bye to the patient and say that please come for a consultation, and then only we'll give you the prescribed treatment. Now, what is also important is that it is as much the responsibility of the patient as it is for you to try and elicit that the patient should give you an accurate information. This is very, very important, that the accuracy of the information, the patient should not conceal anything from you when he or she is going in for a consult. Now, unfortunately, there is no fixed format that has been prescribed for issuing a prescription. The name, age, sex, etc. is something very, very important. But whether you can transfer the prescription directly to the pharmacy without the patient's explicit consent is something that has not been fully written. But I would advise that do not transfer the prescription directly to the pharmacy without the patient's explicit consent. Now, again, an important pearl that I have already said is there is no time period that has been said as to till how long you should keep the records for a teleconsult. But my recommendation would be that ideally you should, as in OPD, you should keep it for 3 years. Now, the next important thing is that if the history or video evidence points to the possibility of a medico-legal etiology, please do not continue with the teleconsultation. That is an advice that I would wish to give you. Any medical legal thing that is likely to happen, please call the patient for a physical examination. Now, what is also important as a pearl is that the patient's personal data should not be disclosed or transferred without written consent of the patient. This I have already told you. Please ensure that it should be a confidential data that is with you. Now, when you are looking at prescribing drugs, another pearl would be that if you have to prescribe drugs like steroids or cycloplegics, be very, very careful. I would say that antibiotic drugs or lubricants, etc., which can cause no harm, should be the best kind of drugs that you should prescribe. If your patient is an old patient and you know that the patient is a case of uveitis, etc., and then you can prescribe steroids and cycloplegics, but otherwise you should be wary of prescribing drugs which can have adverse effect. Now, there is one clause which AIOS has already represented in the Medical Council of India guidelines, which says that an online program will be developed and made available by the Board of Governors in supersession of the Medical Council. This is still not available. And they say that all RMPs have to first do an online, before you go on for online consultation, you need to complete this mandatory online course within 3 years of his notification. So the notification has come, but the course is still not there. So I think for the present interim, the principles mentioned in these guidelines have to be followed, except that there is no way that you can take this online course that is there. Now, the other important thing is that the telemedicine guidelines do not apply to practitioners of Ayurveda, Yoga, Homeopathy, Unani, or Siddha. Now, important again, something that I'll stressing again, the telemedicine guidelines have been published in the form of an amendment to the Code of Conduct for RMPs. Therefore, any violation of the telemedicine guidelines will be looked at as a misconduct at the hands of the concerned doctors under the Code of Conduct. A patient who suffers due to the misconduct has the right to complain to the respective state medical councils with whom the doctor is registered about this misconduct in your practice. So this is what I would wish to say. This is the website from where you can go and download this telemedicine PDF of the Medical Council. And this is what are the guidelines, whatever we as AIOS thinks that what you should follow. But what I am just trying to put as a disclaimer that these guidelines should be used in conjunction with other national clinical standards, protocol, policies, and procedures. So friends, this is just the starting of telemedicine era in ophthalmology and in medicine. And I think this is something that is going to become more and more applicable as time passes. Thank you very much for your kind attention. So I think after this, I'll request Professor Amita Sharma to talk about tele-ophthalmology as to what are the ways, how it helps, and what are the other countries, what they are doing. Dr. Amita.
So it's a pleasure again to be here at this yet another webinar on Corona crisis. And I would like to thank Dr. Mahipal Sachdev for leading the way in this Corona crisis for AIOS members. And I would be talking to you about the telemedicine guidelines. Basically, this would be dealing with the overview of the telemedicine for ophthalmology and it will also highlight the issues in the development and implementation of the same. Now, what we need to know is what is telehealth and telemedicine. So telehealth encompasses everything. So it is a healthcare delivery over distance or time using electronic communication technologies, and it serves to enhance the healthcare access, quality, and the patient satisfaction. Now, telemedicine, on the other hand, is provision of the traditional clinical service delivery, which uses electronic communication technology and often uses a live format. There are many things why telemedicine has a relevance in ophthalmology, and this is mainly because everything in the eye you can see. So there is electronic imaging capability with the biometric data acquisition, advances in the health information technology, and this is then integrated on a widely available broadband activity. So that is why telemedicine is so successful in ophthalmology and is possible. There are 4 domains. One is the live audio video or synchronous telemedicine, which is the real-time communication between the patient and the provider who's using the telemedicine services. And the other is the store and forward, that is the asynchronous telemedicine, which is electronic transmission of the healthcare data, which is in the form of images, text, or other digital data to the provider for evaluation and service delivery. Then apart from this, you can also have the remote patient monitoring, where the health data collection is done and during the typical activities of the daily living by the patient himself, and then it is sent to the provider for analysis. And then we have more informal ways like mobile health, like you have fitness tracker in your cell phones or in your tablet computers, etc. Now, 2 diseases where telemedicine has proved to be very useful is diabetic retinopathy and retinopathy of prematurity. And there is a gray line between the artificial intelligence and the telemedicine, and somewhere down the line you have to integrate both of them together. It is important that everything that you do in telemedicine should be validated, which includes the quality of care and the long term follow ups. It should not be limited by technology or systems. It should be comparable to the accepted standard which is there, and it should be conducted in the clinical setting. So clinical setting could be different. For instance, for diabetic retinopathy, it could be a primary care setting, and for ROP, it could be neonatal ICUs. But all the imaging devices, the field of the view, the training of the images, the training of the readers, all need to be validated. Now, the clinical equipment which is available to us is in the form of information acquisition devices, which could be your camera on a slit lamp, or it could be autorefractometer or OCT or Humphrey Visual Field Analyzer. And all of this then goes through the devices which actually disseminate the images and which help in communication, which could be your computer, laptops, or could be your network systems, or could be the servers. Now, the clinical equipment that you use for telemedicine should be approved by the regulatory bodies, which could be DCGI, or it should be of ISO standards. One should adhere with the state government, central government, and international guidelines. And it should be possible to integrate it with the electronic health records, which is present with the clinician currently. Then you may have to recalibrate some of these devices, and the IT staff should maintain a proper data security, integrity, and availability, including the backup in the archive, and this should be confirmed by by the IT staff at the clinic. Then the setting could be an OPD exam or could be emergency exam, and it is important to get a detailed clinical history as well as organize appropriate follow-up care. And it is important for the personnel at the remote imaging center to be well versed with the diagnostic equipment, to be well versed with the informed consent, to have OPD experience in a clinical setting so that he can extrapolate or simulate the same in a remote area, should be aware of the potential problems such as problems of pupillary dilatation or any other maneuver or procedure that he or she is going to do. And training for safe and proper contact with the patients is essential for such personnel. Then personnel at the remote imaging site should also know should be well versed with the specific devices and adherence to the quality of these images, and should know which are gradable images and which are the images which have to be discarded. Then you have a remote physician who receives initial training and periodic re-evaluation to meet the quality standards for tasks which are being performed. And you have a reading physician. And the important thing is that the reading physician should confirm the medical malpractice liability coverage from his or her insurer. Then the data acquisition again can be in two modes. One is the store and the forward data. That means you collect or acquire all the images and then you store them, and then they are sent for evaluation to a trained reader. Or it can be newer methods, which I'm sure Dr. Grewal is going to be talking about, that is at home testing and then transmission of these interactions on part of the patient. Then the data transmission methods also should be approved by the regulatory bodies, and standards based verification of successful transmission and storage of the text should be there. And there should be alternative mode of information transfer in the event of a primary system failure. So there should be a disaster recovery system, and there should be a system failover backup as well. Then a team of image readers under the ophthalmic supervision should be able to do the image grading and the reading. And important thing is that you should make accurate diagnosis and timely diagnosis, because some of these situations may be emergency conditions, and so timely diagnosis is required in these conditions. Then the activities that are being done should be regulatory body compliant, both in terms of privacy and security. The data should be the data that is transmitted on either side should be received, and receipt of the same should be acknowledged. And it is important to secure and store the data report. An ungradable image should include a recommendation, or should include a prescription saying that the person needs to be referred to in-face appointment and face-to-face consultation, and the remote system in a particular situation may not work. Now, it is important to work on the quality assurance. So you have to monitor the operational process and the clinical outcomes, then specify process and workflow metrics of the application, then the quality of the equipment should also be checked, and then attempt continuous improvement to address failures and technology advances. Now, privacy and confidentiality is, of course, extremely important when you're doing telemedicine, and proper security measures should be taken, including encryption for the data security and the integrity concerns. Now, the impact that telemedicine is going to have in ophthalmology is that the traditional practices may give way to telemedicine programs, especially for diseases which have with less burden, and diseases which has more burden. It may enhance the identification of more patients because you will have more teleconsults into your system, and some of the opportunistic identification of the abnormalities may also occur. For instance, retinal tumor found during a diabetic retinopathy monitoring programs. There are legal considerations in telemedicine, and one has to be aware about the malpractices, the informed consent, and the patient privacy. And of course, the limitation is the infrequent and the inconsistent coverage that may be there, especially from the insurance point of view, and absence of widespread coverage, not only in the government sector but also in the private sector. And that is something which I think needs to be worked at. So telemedicine has come to us during the crisis times, but I think it needs to be, the whole system has to be placed, has to be in position, not only during crisis time, but also during times when we are going to have normal situations. So these are the resource documents where one can look at for telemedicine, which completes quite the picture. And thank you for your kind attention.
Thank you very much, Professor Namrata. You can keep sending your questions as we have access to the questions. And we go on to the next presentation by Dr. Ritika. Dr. Ritika. Jaswinder, can you just find out what's happened? In any case, I'll just wish to tell you there's one.
Can take the questions meanwhile, sir. Yes, Ritika, you are there?
Yeah. Good evening. Yeah, can you see my screen?
You have to share.
Can you see my screen? Is it visible?
No, it is not. Can you share?
I have already shared it.
Okay, I think you need to do it again. You need to do it again, Ritika, after opening your PowerPoint presentation and then share screen. Meanwhile,
Okay.
yes,
Yeah,
it came for us for a split of a second.
Okay. A very good evening to all of you. I'd like to thank AIOS for the opportunity to present my talk on the opportunity in the crisis. Now, like most things in our life are these days made in China, so is the topic of my talk. The Chinese actually use two brush strokes to write the word crisis. The first brush stroke stands for danger and the other for opportunity. So in a crisis, we must be aware of the danger, but learn to recognize the opportunity. Now, putting the opportunity in terms of numbers, India is one of the largest and fastest growing markets for digital consumers. We have 56 crore internet subscribers as in 2018. India has 1.2 billion mobile phone subscriptions, and we as Indians have downloaded 12 billion apps in 2018. Remember that we are digitizing faster than any other country, and 40% of our population as of now has access to an internet, and this percentage is only growing. How does that really change the way we live and operate? So from 2019 January to 3 years later, 2022 January, it is predicted that 70% of the Indian consumers will take a decision to buy a product from their mobile phones. What is very important to note here is that the centerpiece of the digital era is the mobile phone, and the desktop usage has not grown as far as the mobile phone has. So whenever we're looking at teleconsult, we must use the mobile phone as the centerpiece of connecting with the patient, because that's what the patient uses and is accessible through. Now, why is the COVID era the opportunity for telemedicine to come in? We know that Amazon tried for a very long time to shift customers from brick and mortar stores to online. It took them a lot of time, a lot of messaging, and a lot of cash burn. So really, to bring about a change in consumer behavior, you either take a lot of time, a lot of effort or money, or you require a trigger point. A trigger point such as the COVID crisis is really once in a lifetime trigger, because changing consumer behavior requires you to change their heart and mind. And with the impact we've had with the COVID crisis, today the patient understands that there is a need to connect to a doctor even at a distance, and the patient has access and capability to connect with a doctor using technology that is already available. This has also been recognized by WHO and various regulatory authorities who have come forward and said that telemedicine should now be an alternative for clinical services and clinical decision support. So this is the right time to really formalize and crystallize this method of care delivery. The impact of the COVID crisis has been so profound that this is a study that was conducted on US patients a few weeks ago, and they found that 84% of the patients said that they are more likely to select a provider that offers telemedicine over one that doesn't. So such deep psychological impact has come in, be it out of fear or just the whole gravity of the situation. The patient now understands the need and is willing to accept teleconsult. Let us look at the situation on ground as of now. Practo is one of the largest platforms, and they do an average of 730,000 online consultations annually, though only 2 to 4% of those are for ophthalmology. Most of the platforms that are offering teleconsults have noticed a 2 to 10-fold surge of calls during the COVID crisis. Note that ophthalmology is a very minuscule portion of these teleconsults, and general physician, pediatricians, antenatal checkups, dermatologists, and nutritionists are the major chunk. In fact, general physicians have been using it for a long time, and a feedback from the patients is to the extent that 91% of the patient feels that their queries and their condition is adequately resolved by a teleconsult, and they may not need to actually see a doctor. Now, I think we've already gone over a lot of the regulations that telemedicine requires us to have in place. So whenever you're thinking of either building a platform or using a platform, you should look at the functions in terms of the following as a priority. You have to validate the patient details, the name, gender, the age, and the profile of the patient in terms of photographic documentation using an ID. You have to validate your own details. You have to maintain a log and a record of the audio and the video conferencing. You must make sure that your entire communication and the patient record is secured. You are responsible for the security of the data. You should ideally also be able to electronically schedule these consults as per your schedule. Right now, a lot of us are doing it as a social initiative, but later on, as this becomes part of the mainstream, you begin billing for it, and you need an online secure payment gateway for the same. You need a place where the patient can upload images and files in a manner that the data remains secure and the patient identity and privacy is preserved. You can look at even integrating it with your EHR system if the product is specifically for you. I would not recommend this for commercial products. Do note that you cannot simply just prescribe as a chat or as a communication. You need an e-prescription which requires a digital signature. You should try and prescribe over-the-counter drugs as per the present regulations. You can move, that basically means teardrops and other things. You can move to listed drugs which are topical antibiotics. But as of now, steroids, cycloplegics, etc. should be used with a lot of caution, and it is better to call these patients for a physical consult. Now, a lot of us are in organizations, institutions, or group practices where you have many doctors. Each doctor has to make sure that all the protocols of teleconsult are followed, and it sometimes becomes a uniform adherence among the team. To circumvent that, it is better to automate and centralize your telemedicine module so that you ensure all legal regulations are met with. How you can do that is either through self-made chatbots, recorded logs, and digital signatures, or by using any of the commercial platforms available. You can use a commercial platform as a product and white label it. So, for example, Fortis is a large organization, has used a commercial product and they've made it their own. So it is hosted on their server, and they can basically they don't need the patient to move on to the other health tech platform. Everything is on their platform, but you are just using the product from commercially available platforms such as these. You can also look at a customized version with any of these platforms. That means that though you haven't procured the product, they will customize a link so that when your patient visits these platforms, on that link, you will have only your doctors and your branding. Or for an individual practitioner, you may just have a simple listing. Now, there are a lot of commercial platforms available. These are headquartered usually in the major cities of India. You may like to choose one that is headquartered closer to you, simply because normally their largest patient base and their service is best in their area of headquarter. These are just some of the platforms you can choose and actually even take a demo of. Visit is by BITS Pilani alumni based out of Gurgaon, Delhi. Briefcase is by IIM alumni based out of Mumbai. Practo, of course, is one of the largest platforms. MFine is a platform developed by the ex-Myntra founders. Meadow is again a platform which is based out of Delhi, and so is Liberate. You have other platforms based out of Kolkata and other urban cities. Now, most of these platforms do really track the regulations and make sure that most of them are followed. Whenever you look at the platform, they will give you a checklist of all the regulations that they follow. The appointment can be done either using their electronic scheduling, or you can do it basis your EMR also. Do note that an average teleconsult lasts longer than a routine consult, because you have to validate the patient's identity, you have to give your own identity, and you have to ask a lot more questions. So the average time for teleconsult is upwards of 10 minutes in most cases. A lot of people keep 15 minutes as the time slot for one teleconsult, and the teleconsult in many cases stops at 15 minutes. But 15 to 20 minutes is the rough time that one teleconsult slot takes. These are data points from the pre-COVID era. A patient who is wanting to seek a specialist online would prefer that he gets a call back within 10 minutes. We normally at our organization look at calling back the patient within 40 minutes to an hour. Now, like I said, teleconsult takes a longer time, but what can help a doctor utilize his time more effectively is starting the procedure of teleconsult with having a pre-filled form, which includes all the patient IDs, all the patient photographs, previous records, and the history taking. And that can also include, like in this case, the use of a chatbot. This is a chatbot that has been personalized. So you see, once the patient has logged in, this is a general physician chatbot. So it's asking for previous history of any systemic disease, previous history of any drug allergy. So all this comes pre-filled for the doctor. So the doctor is just going to be able to go through a lot of the questions and not spend time asking these questions. And this saves you a good 3 to 5 minutes. What the doctor sees after the patient has filled the form is a WhatsApp-like experience. But note, though WhatsApp is very tempting, you have no data security, no formal e-prescription or a formal way to encrypt the data on WhatsApp. So this is a WhatsApp-like experience, but you're using an app which is for a health tech platform. And as regards data and regulations, you are more secure. Now, you must note that you have to take into account the clinical history and the clinical notes that you're making while you're doing the teleconsult. And these have to be documented much like a routine OPD. In fact, you must store this record for as long as you would do for a regular OPD. E-prescription has to be generated with a digital signature. And once you've done this, you can then start collecting a user feedback. There are various upgradations that continue to happen on the teleconsult models, and a lot of doctors don't like typing a lot. So you have teleconsult models which are integrated with Google Voice and handwriting recognition, which allow the doctor to the flexibility to either handwrite or dictate the clinical notes or the prescription. You can also schedule follow-up appointments. Do note that follow-up patients are the ones which are actually best handled, because you've seen the patients once and it is very easy to correlate the clinical findings of that patient. Now, we all know the Janta curfew came into being on the 23rd, and we were all trying to scramble ways in which we could remain in touch with our patients. So at Center for Sight, we've not used any commercial platform as of now. What we've tried to do is enable our website to become a medium through which we can then enable teleconsults. So this is a screenshot of our website. You see on the right side is a COVID chatbot, the same chatbot with a mask. She gives more information about the corona crisis and what all you need to do while seeking appointments for OPD or when you do enter the OPD. On the other side, we have a chatbot which allows you to teleconsult. We also have a Facebook Messenger link, which also gives more information about teleconsult. So this chatbot, when you enter the chatbot, will give you will ask you certain details, which basically include your age, gender, name, and language preference. Because we are multi-locational, we ask for a language preference between English, Hindi, Gujarati, and Telugu. Once you have given that, it will tell you about the teleconsult procedure and the consent. You then have to accept the consent form and approve the conditions, much like you do on a lot of the sites which ask you for accepting cookies, etc. This approval is stored at our backend, and then you ask them a series of questions. Remember, a lot of people cannot answer all the questions, so you may have the option to skip the question by just pressing an enter. So this patient here, this is a demo, has been asked to enter the specialty, has entered cornea. Then describe your eye problem in detail. And so this is, the patient has entered redness in the eye. Then the patient will be asked to click a picture of the eye. And you can also have here a chatbot talking to him or her about how to take the picture using the device at hand, which is a mobile phone, or give a video link of how a picture should be. Once the picture is uploaded, the request for teleconsult is made, and we end with a disclaimer that the teleconsult request has been accepted and the CFS personnel will be reverting to you shortly. We also say that while every attempt is being made to ensure ideal conditions, unforeseen situations may affect this service. And also, as of this point, we are offering this as a social cause and are not billing for this service. We also presently actually don't have a payment gateway that we've activated. That is something that we may do in the future if required for a commercial transaction to happen before the teleconsult is to be done. Once the information has been given to the patient can be redirected to another page. This is the Facebook page of Center for Sight. You can redirect the patient to any page, a website page, a COVID page, or even your Google page. What the bot does after capturing the information is auto-generates a mail which is sent to the doctor who is appointed on duty for the day. This is an auto-generated mail which allows the doctor to then look at the patient details and the eye picture and any other uploads that the patient may want to give, which may include any of their old records or their old fundus photo. They can actually just take a photo and upload it. So then the call center patches the doctor through the patient. The advantage here is that because you have a call center software that allows you to record the conversation, it also ensures that even though different doctors are on board, you have a call center supervisor directly regulating the regulations that are required for telemedicine. Note that sometimes if you feel the patient is illiterate and doesn't have consent, you may actually repeat the consent form and take a verbal and videographed consent from the patient. Once the consultation is done, you then just end the conversation and send a thank you SMS with asking for a patient feedback. And that allows us to assess how efficacious the patient feels the teleconsult was. Also, after this, the patient is redirected to give us a review either on Facebook or Google, because this really is a social cause and it helps spread the word of mouth. You don't want to market for something like this. You just basically want society to be aware and utilize this as a social platform. So that is how you build the word of mouth using social media. Now, though telemedicine is really in use during the lockdown, it is after the lockdown is opened, possibly in a staggered manner, that it will still stay as relevant. We will be able to do a forward triage of the patient, and whichever patient we feel may not need to step out of the house or is elderly or vulnerable, we may tell them to avoid the OPD. We also may need to see lesser OPD or OPD staggered over a longer period of time because of social distancing, and we may need to reduce the waiting time of the patient in the OPD. So having a pre-filled, prepaid appointment with all the registration details already done, the payment already done, the history taking already done, and the previous records already upgraded, allows the doctor to spend minimal time on the slit lamp with the patient. You can even have an e-prescription sent back to the patient. So this will allow maximum social distancing with minimum time spent within the center, and will be fruitful for avoiding the spread of COVID. And it will not only protect the patient, it will also be a protection for the healthcare workers. In as regards the future, telemedicine is something that will remain relevant later also, because McKinsey Digital India has reported that telemedicine trials have demonstrated that telemedicine will help us reduce the cost of a consult by about 30%. This in India alone may account for a saving of $4 billion to $5 billion, and therefore we'll be able to more efficiently utilize both the resources of the patient and that of the doctor. So this is perhaps the beginning of telemedicine. And I'd just like to end by another Chinese quote from the very famous book now of The Chinese Art of War. Don't depend on the enemy not coming, depend rather on being ready for him.
Thank you very much, Dr. Kritika.
Thank you.
We can move on to the next talk, that is by Dr. Praveen Krishna from LVP. So he's going to talk about the LVP experience vis-a-vis the tele-ophthalmology that they have. Dr. Praveen, please. Dr. Ritika, you need to take off your slides.
Thanks, Dr. Maipal, and thanks to Namrata and Rajesh and the AOS for having me on this platform. Fantastic thought process about the need to talk about tele-ophthalmology. So what I would like to share with you is sort of the experience that we've gone through in the last 2 weeks or so in the area of tele-ophthalmology, and what we've done before that as well. So this is not just my work, but this is work by a very talented group of individuals in the hospital, and I would like to acknowledge each one of them. So I'm going to start with a little bit about what we used to do before Corona, what we'll call it as BC, because of some unique requirements that we had. Then about what we are doing right now in the last couple of weeks, at least what we've set up in the last couple of weeks, and what plans are afoot for the future as well. So this is sort of important because of the fact that it's important to understand how we set up the teleophthalmology service earlier. So LV Prasada Institute is not just located in Hyderabad, but also located in a lot of smaller districts as well as rural centers. So the smallest rural center caters to primary eye care, which is mainly prescription of glasses and being able to diagnose basic diseases. Secondary eye care, which is in the district level hospitals where you have cataract surgery, screening for diabetic retinopathy and glaucoma available. And then the tertiary service, which are the bigger hospitals like in Hyderabad, Visakhapatnam and Bhubaneswar. Now, the reason why understanding this 3 level is important is because earlier, what we did was we used to have a teleophthalmology service that was primarily based in these secondary level centers and the primary level centers and connected to the tertiary level centers. So basically, rather than a patient to clinician interface, this was more a clinician to a clinician interface. So here, what used to happen in the primary centers is the history was taken on a tab, and then a picture of the eye was taken. And this was shared along with a video consult with a clinician who was sitting in the tertiary center. And based on the photograph that was taken, advice was given, and an online prescription was generated in case medication need to be given. There were some modifications like this tab that is fixed to a slit lamp, and did result in some very good quality photographs as well from the point of view of being able to tell what's going on in the eye remotely. But in addition to this, we've been able to do about 3,000 consults like this per month so far. The second thing that we also started doing was something called a drone slit lamp, where you can place a slit lamp that has a robot in it that you can control remotely sitting in a tertiary center. You can examine the patient's eye by controlling it from, say, Hyderabad. And then you also have a slit that you can control, and you can get a good idea of what's going on in the patient's eye. As of now, this is in about 9 to 10 locations, but has been not as successful because of internet connectivity issues. So that was in the past. And what are we doing right now? So what are we doing right now is we set up a 3-level teleconsult services in the hospital. The first level is a telecounselor who receives all calls to a single number. And then there is a flow chart by which the telecounselor is able to resolve general queries about the hospital, when it will open, appointments and stuff like that. If there is a medical query, then they go on to the next level, which is handled by a trained subspecialty fellow, qualified ophthalmologist. This subspecialty fellow again follows up by calling this patient, and if they have a medical query, they try to resolve it. If they cannot resolve the medical query, it goes to the third level, which is to the consultant's mobile. The consultants have access to EMR remotely, so they're sitting at home and they're able to access the patient's file so that they can give appropriate advice to the patient. So at the first level, the telecounselor has a flow of how to follow each patient's queries. And there is also a simple Google Sheet, and everybody can actually do this. A Google Sheet is something that a Google form is something that you can generate, where you can input basic questions or basic fields that you want to fill in, which is later populated in whichever way you want, or it's populated into an Excel sheet. So once the telecounselor fills in this Google Sheet, they also have a FAQ prepared in the local language as well, so that they're able to answer the patient's queries appropriately. Following this goes on to the second level. Now, the second level are 5 subspecialty fellows from each specialty, and they have a workflow as well. But basically what they do is they're able to view an Excel sheet, which is populated by the Google form that the telecounselor fills in, which actually has the patient's name, the time of call, the hospital record number, the mobile number of the patient, and the complaints of the patient individually. Once they pick off each of these, then they call the patient, and then they have to fill up about what advice was given and if an appointment needs to be given in the future. And then the patient care team takes on and follows up. So as of today, we've done about 1730 of these teleconsults in the last 2 weeks or so, which was set up just about 2 weeks ago. Once this is done, then there is a simple Word file which is generated, filled up based on the advice given, and linked to the patient's EMR, so that when the patient really comes back for a follow-up, we all know what has been advised for the patient. Following this is level 3, that is the medical consultant who are sitting at home right now. What they do is mainly resolve queries from level 1 and level 2. They also call their individual OPD patients, which is about 60 a week. So they've been about 3,000 teleconsults at this level. So this is the 3-level approach that we are following, and it seems to be working quite well. But for the future, this probably is not going to suffice. So the goal that we are looking at for the future is to be able to reduce footfall for mainly follow-up patients by about 20% across the network. So on an average, that will be about 700 patients per day, which is what we are aiming for by the end of the year. New patients seems to be a little challenging at this point of time, but we're going to take that up in the second phase. The main goal of this is to achieve social distancing, like Ritika shared, and also to create a robust, equitable, and a patient-centric teleconsult services. So there is a process flow for all of this. So the important components of all of this is infrastructure for connectivity, good patient interface, enabling remote eye examination, trying to integrate the data that you generate into your medical records, ensure that there is a healthy and an appropriate patient-doctor interaction. And then the last bit is again an interesting part, to integrate home care into all of this. So few points about each of these. Infrastructure for connectivity includes telephone lines. We've already set this up. We've been able to redirect all calls to the hospital, even to mobile numbers of people who are sitting at home. Significant HR and training exercise, and also setting up of IT and support services, and then ensuring confidentiality and legal aspects of the consultation. The second thing that we're working on right now is the patient-clinician interface. We've built a bot using AI to be able to screen patients, to direct them to the appropriate specialty in case they're new patients, and also to ensure that they're able to go to the correct specialty to book an appointment in case they're follow-up patients as well. So this also helps to identify suitable patients for teleconsult. And then once this is done, we're also building an appointment system, which will be both patient-facing and clinician-facing. So the clinician will actually see appointments for him or her on the teleconsult module. Patients will get an appointment time on the teleconsult module. And then as of now, we have a video interaction, telephone interaction, but eventually the goal is to create a video interaction between the patient and the clinician as well. The other process that we're trying to explore is a remote eye exam. There are multiple ways in which you can measure visual acuity, visual function, also imaging the eye remotely, ensure that you measure motility and function. All of these need to be validated because all of these are probably just coming out and are pretty primitive at this point of time. So we'll need to spend some time trying to validate each of these as well. Following that, the next step that we're following is trying to integrate all of this data into the EMR so that when the patient comes back to the hospital, there is continuity of care. You can do this synchronously, that is at the same time that the consult is happening, or asynchronous later on after the consult is over, where you push the data into your EMR. We're also looking at how to ensure that we record all documentation and also set up an audit process and a feedback process so that you control for quality of this system. So the brief flow of what we expect to happen in the future is if a patient actually seeks an appointment, then he gets a message either from the hospital or from the teleconsult service. From this message, he's able to download an app on his phone, which will enable the teleconsult to begin. Once he enables the app on the phone, then he's redirected to a consenting process. Once the consenting process is done, then the patient can either write down his medical history or record his medical history using voice and then upload that onto the app as well. Following which he can probably upload medical reports that he's sourced from the past or from other consults elsewhere. Following this, hopefully we'll be able to have some measure of measuring their visual acuity or visual function. We also are planning to have a device that will be able to image the eye, at least on the external part. We're pretty sure, confident that we'll get a good picture of the external face as well as each individual eye as well. Eventually, maybe a video recording in cases that you want to test movements too. And all of this is one module. So the patient has not consulted the doctor yet. But once they finish all of this goes to a payment gateway. In some cases, where the patient is not able to do that, we expect a tele-help center to be able to aid them in all of this. And once this is done, they go to a payment gateway. This is mainly for new patients. And then they schedule an appointment with the doctor. Once they schedule an appointment with the doctor, then at that point of time, the doctor is available for an online consult. And at this consult, we expect that the patient will actually... All right. So following this, we expect the doctor to be able to generate a prescription. And after the prescription is generated, we also expect the doctor to be able to generate a medical report as well. So once a medical report is generated, then the doctor probably will be able to fix or schedule an appointment for the next visit for the patient. It could be an online appointment or it could be an on-site appointment, which is the second part of the whole consultation process. After this is done, we expect a third component where we upload all of this into the electronic medical record. And finally, what we expect is to have some module of home care also built into all of this, where somebody able to carry devices that are mobile can travel to the home of a patient to complete the examination, whichever way they want, and then upload all of these reports into the same way that we have uploaded using the app. This probably is going to be a more comprehensive examination. Also, this can be done using a clinic-based system where the patient does not need to come to the hospital, but maybe visit a clinic that is at a distance from the hospital where he or she will be able to undergo the same kind of examinations. Once this is done, then all the data goes into the EMR, and then through the app or through the phone or the call center, the patient is able to schedule an appointment again. And once the reports are available, able to consult the doctor. So this is the future plan of how we would like the teleconsult services. And for home care, the innovation center that we have has already generated a number of mobile devices that are handheld. The one that you see on the top left-hand corner is actually a device to measure refraction on screening. Then you can measure pupillary function using a Pupil Plus device. There is the mobile handheld topographer that's been developed. Then a mobile handheld device to measure visual fields. And once all of this is done, there is a system called the Bifrost, which is an interface between the reports of all of this to integrate into the medical record system. And once this is done, then we expect the patient's records to be available for the doctor to see. So eventually what we expect is, at this point of time, we are working on version 0, which is just the telecounselor, the patient and the doctor, and connected to the medical record. Version 1, we hope, will be able to have a proper appointment scheduler so that we can actually merge the patient's requirement of time and the doctor's requirement of time, and the appropriate doctor as well. Version 2, which we hope will probably take about 3 months or so, would be addition of an imaging device, as well as the ability to generate reports as well as prescriptions, and also to be able to measure more parameters from the patient's eye. And eventually we want to add a sort of a home care kind of a system, as well as outreach centers where the patient can visit without coming to the main hospital. So this is how we see the way in which teleophthalmology or teleconsultation is going to evolve, at least from the perspective of LVP. Also remember that this is not just for people who have a smartphone or able to handle it, but we also need to cater to people who probably do not have a smartphone, and also to people who might only be able to call you or speak to you on the telephone as well. Thank you very much.
So thank you, Praveen. I think that was a very elaborate telemedicine in ophthalmology, which is going on at LVPI. And there are again a lot of questions for you, but I think we can take the next talk, sir.
Yeah, I think we'll go on to Dr. Sudhir to talk about the SN experience as to what they are doing and how they are faring. Dr. Sudhir, please.
Good evening to everyone. You're able to see my screen?
You have to start.
You have to double click to enter full screen. That's what they say. We aren't seeing your slides, please.
Please share it again.
Yeah, that's fine. Okay. Just go on to slideshow now.
Yeah, I'm on the slideshow.
Yeah, sure. Everything's fine. Please go ahead.
Yeah. Good evening to everyone. I thank Dr. Amita Sharma, Dr. Namrata, and Dr. Rajesh Sharma to have me in this webinar. It has been a really good presentation so far. So we want to present and show how we could do all whatever has been our experience in the last 1 week, and how we have taken it forward. As Dr. Praveen has told, we have tried to integrate, and we have come to the second step from version 0 to version 1, and we integrated all these things in a matter of 3 days, tested and rolled out. And currently, this is the scenario. So I'll take you through the process, what we have done and what we have achieved so far. So the background was when the COVID lockdown happened, we had more than 3,000 surgeries. Appointments had to be cancelled, and these are the follow-up appointments for the final checkup. And most of these patients started calling to our operator. And when we started getting calls, we are unable to see the records of these patients, and we don't know who the patient we are talking with. And when we had spoken to these patients, unfortunately, we do not capture them, and it is not going into the electronic medical records. So we try to see how we can integrate all of them and get things moving in a smooth fashion. And we wanted to mimic what we were doing before and see how, if we can get into the same scenario, can we sit and do this sitting at home? So most of them said, can doctors do work from home? Yes. And we integrated all the telemedicine guidelines, and from A to Z what Dr. Amita Sharma has elaborated. So I will take you through how we have done that. So the first approach was we need to prioritize the appointments, because we said there's so many calls. So we wanted to attend to, the first thing is all those surgery patients whom we could not take care, because these are the patients who are more vulnerable and we need to handle them first. So then we wanted to segregate them into those patients who had given short reviews, and then those patients who had regular consultations which were cancelled. And then we opened up to the general patients who can get into our teleconsultation. So one good thing we had a very good EMR for almost 16 years, which we worked along with TCS and developed as a co-brand. And we could use the background of that and identify these patients. And we also had a very good cooperation from all the consultants, where we could take 1 hour of their time, dedicated time, which they can allocate to teleconsultations. so that we could allocate appointments to them and they can start calling the patients or get connected on the video calls and then communicate with the patients. So the approach too was, so we had to use SMS gateway providers to send proactively SMS to all these patients, asking them, since you could not come to the, your appointment was cancelled, we will be able to connect you to the doctor whom you have operated. And once these patients agree and give a consent to us, then we identify the time slot when the patient wants to get connected, and then we added up all of them, collated all of it and generated an appointment schedule for the consultant. And this was integrated through our Gmail accounts. So this is how we started. So we started sending an SMS, personalized SMS to the patient, and they need to click a short URL through which it will take you to a page where they need to choose the appointment time, go through the consent process and agree to the consent. Once this is done, an email is generated to the consultant, and they take, and by clicking on the email link, they get to see their entire appointment scheduled for teleconsultations, and they need to go through the process. So this is how they get so this is a screen which shows you the appointment screen which we could develop integrated with EMR. So when the patient chooses, either they get a phone call or a video call, or there may be chance that patient even never respond because the phones are switched off, or the patient has given a different wrong phone numbers, and all scenarios we could handle. So when the patient chooses to have a video call, we connected this to our Hangout Meet. So how does the Hangout Meet? Is a video call through which the patient, the time when the patient wants to get connected and the appointment gets fixed on the video call. I'll just take you through a small video how this happens. So when the patient selects a video call, automatically appointment get fixed on our calendar event, and then we need to go through the calendar event and say join video call. So automatically it will get me connected to the patient, and I can go and continue with the video call. So this is the easiest way to do, and the patient can also upload whatever documents they have through the Hangout. It is as any other Skype call or any FaceTime meet where you can talk to the patient and even upload and share the documents. So this is the first scenario which we could handle for a video call. The second one was a phone. How do we handle the patients who could not have access to web or access to internet? So then we tried doing what is called phone calls to this patient. So again, we didn't want to take a load onto our operator. So what we did is we connected to our cloud telephony service. So based on the appointment time, the cloud telephony automatically connects the patient with the doctor, and this all happens automatically, and your phone number is completely masked. So that is the most important thing. So the patient doesn't know from which phone it comes. It will be in a Shankar Netralia's phone number through which it comes, and the patient once get connected, then the doctor can start conversing, and at the same time the doctor can also see the case sheet on the other side. So I'll just show you how it is done. We also have a plan B. Most of the times, because of internet issues or some issues, the patient doesn't answer the call. So there may be some dropout in the cloud telephony service. So we had a plan B. So we had our entire secretaries who are free, and we wanted to take help of them, make them work from home. So these phone numbers are shared to the secretary, and they can do a conference call with the patient and connect to the doctor. And once they can connected, we can access the EMR and go ahead with the complete call and document everything. So this is where the third approach where we could get our EMR enabled onto this current platform, what we have done. And only thing we made secure this, currently the entire EMR has been on the cloud platform. Only patients whose records needs to be pulled out from the main EMR are available on the cloud, so that we take care of all the security, because if there is any hacking or anything, we are protected, because in the current crisis, we don't want to take any security issues. So we could move all these patients who had an appointment or who got operated into a different server, which is easily available on the cloud. And based on the appointment sections, all these appointments are case summaries are available, and we can open up the case summaries and go ahead. So the consultant on the same appointment screen, they can pull up the case summary. They can go through the entire case sheet. As the patient is talking or as the patient is on the video call, they cannot see the case summary, but the consultant can see through what is the complete case summary of the patient from day one to the last visit. And they can answer up all the queries, and even they can go through the medication prescriptions, what they have doing. So having addressed all these things, we had one more thing. So when I have to communicate to the patient, how do I give a prescription? Because I'm either on a phone call or on a video call, or I'm on a conference call with the secretary. So we try to see how we can easiest way to send a prescription. We thought send SMS to the patient, again, same through the same dashboard. So we did a comprehensive SMS design where the patient name and what message we are going to send, our details with the registration number, and in case we need to change the medication or we had to give medications which we can give can be typed out, and this goes to the patient as a send SMS message. And all these are documented on the back end, and they get integrated with EMR at the end of the day. So we also have an option to guide the patients how to take images, so they can upload them during our video calls. So there are good videos which are available on YouTube. This one, which I picked up recently, done by one of the vitreoretinal consultant, Dr. Jaitra, and the link is available. It is a beautiful video.
For around 3 seconds. Then
So
towards right for 3 seconds, towards left for 3 seconds, look down and lift your eyelid for 3 seconds.
So basically, this is like use the back portion of your back camera for capturing a very good quality images. And one needs, if you have a selfie, if you want to take yourself, you can go in front of the camera, so you can see whatever your image, what you're capturing, or whatever video you're capturing on the through the mirror on your what is being captured on your video screen. And you can take a high quality images, and you can also use the volume button to click the button, click the photo, because if you are going to use the screen, then it is very difficult. And to focus, ideally you need to keep it 10 centimeter from your eye, and then click on the cornea, and then start taking an image. You get a very good images. So just on a trial, I did few patients yesterday. I had a few video calls. The patient had an issue, and initially they sent me an image which was very poor. So immediately I sent them the video link, and they could do a beautiful, a very good clear picture, and I could identify what the lesion is, and you can go ahead. So this was just a trial run which we did yesterday, and now we are trying to see if this can be made as in the FAQs, where the patient can go through some of these available videos. They can do it on their one. So having done all these things, we were proactively sending SMS, trying to see patients who have missed the appointments, all those vulnerable patients, like those who had intravitreal injection, those who had surgeries, who could handle as a first step. So once we had done, we had opened these appointments on our web page, so they can, those old patients, because we have already done KYC, we know who they are, so they can validate the MRD numbers, and they can fix the appointments on their own. So this has been rolled out, and so now they can do all the teleconsultations, appointments, fixing on the patient. And currently this is all done free of cost. So post COVID lockdown, I think Praveen has taken through. So we have already done most of the things what needs to be done. The registration part of it has been done long back. So we send a link to the patient, so they fill all the registrations, demographic information. And we also did a COVID consent form online. So this was done just before COVID. And we also trying to connect to the secured payment gateway. So this is like when the patient is going to come to the hospital, or if you're going to do a teleconsultations later, we can reduce the time at the cash counter. And we have also working on the online history taking, either using an iBot or a simple Google forms where they can do all the filling of the history. And we are also trying how the optometrist can be taken into this entire process. So there are few apps which can help to do a vision check. So the patient, the optometrist can guide the patient to place, like there are iPad related vision screeners, where they need to place Snellen's visual acuity charts 3 meters, and ask the patient to close the eye and capture all the vision related information, and then take the pictures, upload them. So these are things which optometrists can guide as a first level. Once everything is done, they can direct to the patient, to the consultant who can take forward. And finally, we also thought to reduce the time during dilatation, we thought every flow can have a fundus photo camera where the patients can have undilated photo of the fundus, and which gets integrated automatically with EMR, and the consultants can go through them in case they need a dilated fundus evaluation. They can do it for selected patients. So this is what we plan to do at the post-COVID lockdown. There are some options for people who do not have all these integrations, which we could do all that within a 3 days time. And we had a very good support from all our IT staff, and we could roll down. We did a good training, online training, and we could now complete almost 1,200 teleconsultations one-to-one with the doctor directly. And currently, these are other options where people can start using. Very simple is they can have a Hangout Meet call and post it on their website and make the other doctor available for particular time, so the patient can connect anytime and then talk to the patient. So same thing you can do with Zoom link, WebEx link. Currently, WebEx is giving 3 months free connectivity for during COVID lockdown. I'm also have my concerns with WhatsApp, but currently when there is an emergency, we can still use them, but we need to document everything. Currently, the WhatsApp servers are not available in India. As of now, they're all in Singapore. Any healthcare related data, the server has to be in India to use the WhatsApp related, any applications to be used in healthcare. And you can also connect to local EMR. I think Praveen also tried to see they could connect to their EMR using TeamViewer. So there are applications using VPN or AnyDesk where we can connect it. So these are few options which you can do. So what we lessons learned, we need to keep communicating with the patients. We should not lose touch with the patient. Very good teamwork. Every resource is important. Involve everybody in team during this current COVID lockdown. Distribute the work and manage stress. Train your staff for the new workflows, because these are very important, because the workflows keep changing every day. You have to manage surprises, have a plan B for every contingency, and you should incrementally, you have to do all the incremental innovations. Don't implement on one shot. Use a big bang approach. Don't do a big bang approach. Go step by step and increase it. Ideally, if you have a very good EMR and cloud capabilities, integration with the outside APIs are very simple. Finally, at the end of the day, the patient delight, patient satisfaction is very, very high. We started getting patient satisfaction analysis done, which is giving very high results, and that is something which are very gratifying. So I stop here and I thank entire team, entire consultants, entire secretaries who had could cooperate and get things done in very short time. Thank you all for your patient listening.
Thank you very much, Dr. Sudhir. I think it was an excellent presentation. We go on to the next speaker, that is Dr. SPS Garewal from Chandigarh, Garewal Eye Institute. So welcome, Dr. Garewal. We'll wish to have a peep into your experience, as also what the future holds for teleophthalmology.
Thank you, Maipal, and thanks to AIOS for organizing this, giving me a time in it. And I think there's excellent thoughts coming from all of us. Can you see my screen, please?
Your screen is visible.
Is it visible?
Yes,
yeah,
sir.
everything is good. Please proceed.
Okay. So I'll be dividing my presentation into two parts. The first part is where we are at GEI, and the second part will be the potential and the pitfalls. Now, the flow that we have at GEI is that the patient registers online, goes to the website, and this is the interface where he is asked the option whether he is a new patient or old patient. If he's new, then he writes his name and a contact phone number. And once the phone number is written, then OTP goes to the patient. He has to confirm the OTP. And after that, he's the email address, and then the email address is confirmed in the background. And then is the payment gateway where the patient makes the payment. And after the patient payment is made, the patient gets ID number, and then he has the consent form online, which he'll be filling the consent form, and a brief history sheet that he'll be filling online. And then if he has any pictures and taken any pictures, that will be uploaded. Now all this is completed, and then the patient presses the submit button. And after that, SMS, confirmation SMS goes to the patient that he has been registered, and this carries on the instructions. And also SMS goes to the concerned consultant, which mentions the ID number, which will be confirmed with the patient. And also after that, the doctor will be contacting the patient, talking to the patient, and also have access to all the information which has been there on the website. And the doctor will be able to see this, and then the Skype or any other video call, talk to the patient, any other symptoms to be elicited, review the images which are there, and then make a provisional diagnosis, which is documented onto the website, and prepare a prescription and send the prescription by email or send briefly as SMS. And then finally, whatever has happened will be saved and then printed, and then it is attached to the patient's file. And all these are the different steps where the patient has to go through for the teleconsultation. These are the brief American Academy of Ophthalmology checklist that one can go through and see what are the recommendations in that. And each of these patients will have a free visit, physical visit, as early as possible and convenient for the patient. So they pay for the teleconsultation, but then they will not be paying for the next visit when they come to us. Now, this is briefly how we are planning it. Part of it is implemented. Now, the second is the few of my thoughts about the telemedicine. One question is, what about the small practices? And my take on that is that the small practices have more personal relationship with the patients. They are easily accessible. Many of the patients will have a mobile number or a phone where they can easily contact the doctors. And these are the ones where it is the telephone medicine. And I feel that they are more easily accessible to their patients in their feeding area than much bigger hospitals, which have bigger things too. Now, what we want to accomplish, what is the objective of the whole telemedicine? Now, this is something each one of us has to think from our own angle, from our clinic's angle, from our perspective, that for me, what are the objectives of embracing this technology? That is very, very important, because again, the implementation, the use will vary from doctor to doctor. Is it just for revenue that in these Corona times, are we looking at generating some revenue for this? Will it replace the regular visits in times to come? Or is it just a stopgate arrangement for the next couple of weeks, and then once everything is done, we forget about the telemedicine? Legal liabilities are a major issue, and honestly, we do not have a clear answer as yet. IT and cybersecurity considerations are very important, and in the past, some of the platforms that came on telemedicine have been recalled. So there is that issue also in this. Now, one good business model is the second opinion. Now, second opinion, I mean, is where a patient wants to have a consultation. He has already shown it somewhere else. He already has all the reports with him. And these are the situations where patient may avoid a physical follow-up, and all the images and reports are uploaded into the website, and the doctor can give a consultation. This is something which I see may last for a longer time after the COVID is also over. Now, one important thing that we all have to look at is the chair time. We always talk about the chair time. Now, telemedicine, as Ritika had also mentioned, telemedicine will require much more time per patient. Can we, the ophthalmologist, afford that much time from our busy practice? When the clinics open, will we have time to spare for telemedicine? Or are you ready to sacrifice your personal time if you are too busy in your working hours? Now, these are some of the questions which each one of have to answer, and each one of will have a different answer to this question. And that is, again, will decide what objective is for going into the telemedicine. Now, is it a business model? Is it a good business model? I feel the cost of running telemedicine will not be offset by the revenue generated from it. Our current business model of practice is based on patients coming to our facility, getting the treatment, and responding to the treatment. And let it not be dismantled in times to come. We are, as such, a vulnerable profession. I must compliment the Sankar Nethralaya and LVPI model. These are excellent models, and they have everything under their control. And this is very, very important. And this is what I'll strongly recommend to everyone who want to go in for telemedicine. Please have everything under your control. Giving control to the third party will not be a good approach in the long run. Otherwise, finally, the control may go to companies like Amazon, Google, Facebook. They will set up virtual kiosks for pictures, for OCT, for refraction, and they'll have the algorithms which will decide which patient to go where. They will charge from the patient and pay only a part of it to you. The short-term gains may be long-term loss. And already we know that Lenskart Practo have already an evaluation which is much more than many of us. But it should be just an additional facility which should be available to our patients without impinging upon the time and resources of our current physical visit model. Now is the AI. Now we are all hearing about the AI a lot these days. I hope that we all understand what all this is. My thoughts are that AI with telemedicine can be a very deadly combination. Our intelligent fundus camera and intelligent OCT are not far away. They already exist in the labs where they can give you a diagnosis. And similar thing for anterior segment should be available soon. Once we have enough trained data, the predictive models will be very accurate. The future is, my take on the future is that it is like a fiction science coming true. Anything that you can think or imagine at the moment will be possible in years to come. The technology will progress very rapidly. The cost will come down. So we'll be able to do much more at a much less cost. And in this situation, we need to safeguard the interests of the ophthalmologist and be at the forefront of development of telemedicine. Let no one else grab the advantages of the telemedicines from the ophthalmologist. And my final slide is that it is not a substitute for a physical visit and the human touch. So it does have a role, a limited role. It should remain under your control. It should not be taken away by the third-party vendors away from us. Thank you so much.
Thank you very much, Dr. Garewal. Indeed, very insightful as to what the future holds. I'm not very sure whether the big guys will not take it away from you or from us, but I think there is obviously an opportunity which one has to look at and be part of it. We go on to the final presentation by Dr. Devashish Bhattacharya, past president of AIOS and head of Disha. So he'll just be giving what Disha is doing. And then we are open to questions. We already have close to about 150 questions. So Dr. Devashish, over to you.
Yeah, are my slides visible?
Yeah, everything is good. You can start.
Right. Thanks, Maipal. And we just give you a brief overview of how we went around this COVID crisis. We locked down ourselves on the 21st Saturday preemptively. The state, West Bengal, locked down on 23rd from 5 p.m. and the national lockdown came on 24th, 12 midnight onwards. Well, the overall workload that was that we have is about 4,500 patients per day and 450 surgeries. And we have this running on an 80% appointment basis. So it's across our 15 centers. So first thing, we converted all our appointment section to work from home. So we use the AMIO platform. So this, our 30 callers could take these calls from home. Then a list of the surgeries to be done with their EMR and the tests included were forwarded to the respective consultants. Then the job was to postpone 3,000 surgeries based on the feedback from the consultants, because they had to decide which was a surgery which is an emergency and which were not, and also an appointments like follow-ups and something of the sorts. So they had to sort this out. We left it to the consultants and they did a fantastic job of it. And then the callers went around cancelling them with attending all the queries as was possible on the day. And then we, if there were any medical points around that, so they were forwarded and free to call the consultants back. The consultants themselves talked to the patients which required immediate intervention if there were any emergencies. So generally we take around 3,000 calls, but immediate post-lockdown, there was a huge outburst. We could not take a lot of calls, but over time the calls came down, and now for the last 10 days, I think we are on an average 900 calls per day. So we started our chat portal on the 27th of March, seeing that it's a 21-day thing, and just to be on the telemedicine side. But yeah, I mean, so I wouldn't say that the response was huge, but our connect with our patients are pretty good, we think. We have 2 lakh followers on Facebook, and we have we also had a SMS blast. We gave about 5 lakhs blasts of our 40 lakh data bank that we have. Over this 15th day, I think what we did is, as per consultants, the list that you are seeing, we had 44 injections, 30 vitrectomies, cataract for Morgandian cataracts or phacomorphic glaucomas, dislocated cataracts in the anterior chamber. We had 1 case. We did 4 therapeutic penetrating keratoplasties, but we are out of tissue now and eye banking is not possible. Silicone oil removals, repairs, tarsographies, well, these were the usual pattern. Now to tell you that the portal facilitates attachment of images and documents. It's on a Talk2 platform. This is a self-made, and the queries are read and then they are forwarded to the doctor with the EMR attached. If need be, we also upload the tests, previous tests, and the reply is forwarded to the patient. So this is the current mode of operation of our telemedicine thing. So if required, the doctor connects also personally to the patient, and just a moment, patient, and the emergency cases are asked to contact the nearest branches. Our response was modest. We started maybe on 27th March, and till date, we had only 200 free online consultations. So we, of course, want to add this, and for people like general practitioners, I think we heard a lot of planning from the Sudhir and from Praveen, but and also a word of caution from Dr. Grewal. But I would say, a small aggregator like we have chosen Care Clues, which are Calcutta-based aggregator. What they charge is 1,000 rupees per year. They can just place this whole thing on your website, and it operates in the same pattern as has been told before. So they are partners with Apollo Clinic and ILS, which is a local chain of multi-speciality hospitals. So I think, for 1,000 rupees per doctor, if we can have this portal, and it can also take care of the appointment section. You need not expose your EMR also to them. I mean, all that is, they handle this part and the transaction part of it, and the rest of it, the EMR, at the teleconsultation, if the patient is an old patient, then we, our IT people can actually facilitate the previous record portion of it. So I think in this way, we can, of course, stay abreast with this, because we need to think that if Dr. Grewal is very rationally worried about the big players coming into the scene like Amazon, Google, but then we need to be on the platforms also. And as Ritika pointed out, it is a good opportunity for us in difficult times. So that's what we did in Disha. Thank you for your attention.
Thank you very much, Dr. Devashish. I think that was an excellent presentation. Now we can go on to the question answer session. I think we'll have it for about half an hour. I think there are a couple of questions that have come in. I'm going from actually the initial questions that came up. There are some questions which talk about fundus photography. How do you check pressures? How do you check vision, etc.? Can you have a drone slit lamp? So these are a couple of questions which are pretty futuristic, and as to how we can do that. Anybody, Dr. Sudhir or Dr. Praveen, you want to talk about drone slit lamp, pressure checking?
Drone slit lamp is in the context of social distancing. So Dr. Gaurav Luthra suggested that if you're using it, can you use some model like this in your own OPD so that you don't come in contact with the patient too much?
Anybody has? Dr.
Praveen,
Sudhir, Dr. Praveen?
Regarding the visuality, I think as I discussed, there are plenty of apps which we can guide the patient and take a vision and slit lamp. But the fundus photography and the drones are maybe good at the clinics, but we are now talking about something what we can do at home. So at home, it's not. Absolutely, we cannot do anything at this current scenario.
Yeah, so Gaurav is wanting to find out how to check the pressures at home. So I really don't know.
Yeah, for the benefit of the audience, I think there's certain things which are under trial. That includes an implantable device in patients who do have glaucoma. And if you implant that tiny pellet through the Bluetooth, you can actually monitor the IOP up to 80 times a day. So this is the future. And they're also looking at IOL versions, which actually click a photograph of the fundus. So these are both products which are futuristic, but they are actually under trial and they have been implanted in animal eyes.
And I think Google is also working on a contact lens by which you can actually keep checking the blood sugars, actually your the glucose level in the tears, and therefore giving. So obviously there are going to, I think Google is working with Arvind for artificial intelligence for fundus and diabetic retinopathy. So there is, they have tied up with Nikon and Google, so they're trying to do that, and ultimately Tele, ophthalmology and AI, as Dr. Garewan was saying, is going to be something very important, where maybe they are planning to put up these things in malls and take pictures and do AI and tell people that, okay, you have a diabetic retinopathy or you have something and you need to do a consult. So there's a question for Dr. Praveen which says, if you have done a teleconsult, what is the level of satisfaction? Do you still have to see the patient?
From the doctor's perspective, obviously level of satisfaction is low, but we've been doing a feedback of all the patients that we did a teleconsult for. Every 10th patient, we do a feedback call. And it seems that 95% plus have their queries and their problems resolved. But remember, this is for follow-up patients, not for new patients. So when it comes to a new patient, I would expect that number to drop quite a bit. To follow up on, to follow up on the previous question about being able to measure things in the eye, I don't think we should ever expect teleophthalmology, at least not in the near future, to substitute what we can do in the clinic, at least at this point of time. Maybe in the future, yes, but at least for the next several years, being able to measure IOP or other parameters remotely, I think is going to be a very cost-intensive kind of module. If you want to do something like that, then there should be some sort of local system where you have a tie-up with a local practice that the patient can go and get his measurements done and then send those reports to you. That probably is more viable in the short term. About imaging devices, there are several imaging devices that are not for teleophthalmology, but are available to take pictures using macro lenses. You can find on Amazon and you can find on Flipkart as well. You can actually try a few of those. Some of them give very good images, but then again, how does the patient get their hands on that is going to be a question.
So actually, when you're looking at vision assessment, there is a company in the US which is trying to ship out these vision testing equipments which can be attached onto your iPhone or your Android phone. And you can actually check the vision and it will be so cheap, around $200, $300 or something like that. So you can get it into your home and you can do the self-testing. So let's see, because there are a lot of companies that are working on this particular thing. This is actually the largest optical chain in US that's trying to do that. Dr. Rajshekhar, a question for you. How do you think the people are saying something about AIOS helping them, etc., get payment gateways, etc.? So how do you think societies can actually help in getting?
In telemedicine, I feel societies have a larger role to play at this point of time, because it's a change that's happening. And during this change, there are a lot of small practices which are unlike LVPI or Shankara or Disha, where a lot of money can be put into IT infrastructure. So societies can educate people about how telemedicine is, and then also about the types of telemedicine. It's not just that you give the entire prescription. It could be both the patient and the doctor. Both are outside the hospital. Sometimes what we are talking in terms of tertiary center, taking the secondary and primary center, there the doctor is in the hospital and patient is somewhere else. And there is one more model where patient is in the hospital and doctor is away, where it can be transferred. And again, we are very effectively using the chair time issue came. Here, the chair time in terms of face-to-face chair time, you can much reduce it. After the patient gets registered within the hospital itself, we are doing a video call with the doctor so that he can take the entire history, that 3 to 5 minutes of history taking, and all that can happen through a video call, and patient can enter the clinic into the consultation chamber only for a slit lamp examination, and further examinations can happen outside. This may be relevant during COVID time, but extending it will reduce the actual doctor's chair time. And with regard to societies, since there are a lot of platforms available for each clinician, it becomes difficult to choose which is right. So societies can evaluate, negotiate with them, price it them, and then bring it to the society. At taking a cue from all of you at AIOS, at Karnataka Ophthalmic Society, we did a small exercise on that. We evaluated a lot of platforms, and now we have zeroed in on one. And he is providing for the entire KOS members, the 2,500 members, this platform, which is more doctor-centric. Like, it's a doctor has the application on his mobile, and he will send out a link to the patient, and he will also send out a code. That patient registers that code, and the application gets loaded in the patient's app, and that patient is able to get connected to the doctor through a appointment, payment for the appointment, as well as a consultation on the system. And this also can be registered with the existing softwares that they have. The society at large is doing this kind of a negotiation, choosing in on, educating and taking them along. And going forward, sir, at AOS level, Dr. Vaipal, you will have a huge role to play, because a lot of legal issues will come. Using this window, at least now, many circulars that come out from Karnataka government, it's saying telemedicine, we want doctors to enroll for telemedicine. So people have opened up their mind to this telemedicine, which was earlier saying that no to telemedicine and a lot of ifs and buts. Using this window, we should bring in good legislation where it's pro-doctor, pro-patient, as well as it finds its own place in the coming days, so that we can leverage this technology, wherein we can take the best of both worlds to the patients and to the ophthalmologists as well.
Yeah, I think
I guess that's one reason.
Sorry,
yeah, that's
Rajesh,
one reason why there are so many questions on legal issues, that what are the legal implications, and people have given example like if you have a red eye and if you know, by mistake you thought of it as a conjunctivitis and it came out to be a uveitis, and then whether there will be legal implications or not. So there are many questions giving various examples like that. So what is your opinion on that?
See, for this, Dr. Mahipal's initial presentation was excellent. So there is a limitation there. At the same time, there is an opportunity there. See, if you take a patient, suppose a patient is coming to me and requires multiple follow-ups. Some patients, if I call them after 2 weeks, they would say, I will come after a week. Medically speaking, I may not need him to come after a week because I don't expect much to happen. But that consultation, I can this thing schedule it on teleconsultations. So some portion of it you can push there. And at the same time, when it is not possible to meet at all, you will have a platform wherein at least you will know whether it is urgent or it can wait. So now, like Dr. Grewal was saying,
Rajshekar, you said that you can put the consultation again. So there are multiple people who asked this, that suppose there is a teleconsultation or you advise somebody on telemedicine and the patient is not satisfied and you call him for a physical consultation. So would you charge face-to-face consultation? Would you charge again to this patient, or would your charge vary as opposed to when the person comes to you, as a first point of contact with face-to-face consultation?
This is a very individualistic question, because if the teleconsultation fee is reasonable and if he is coming for the same condition within a short period of time, generally you may not charge or you may charge very less. But again, if it's different, so there is no hard and fast rule here. Depending on an institution, they can take that call.
I think Dr. Garewal said he doesn't charge.
Another thing, Mahipal, 23rd March was celebrated as the Telemedicine Day. So, President AIOS, you must take it into account and, hit when the iron is hot. So, all these medical legal issues. And that's why actually, we really, one, of course, because we wanted to get out and be connected with our patients. The second thing is it is a good starting point, somewhere it happens like this, that, unless there is a need, an invention or a new area doesn't get exposed. So, yeah.
I think I fully agree with you. The COVID has actually brought the thought process away from this. Like even the Supreme Court is now doing their hearing by video conferences, etc. I think things will change. Work from home will continue for some more time, I'm sure, whether there's a lockdown or not. But I think the thing is that there is going to be a lot of distancing that is still going to be continuing. So I think these things have to be brought into practice sooner or later. The only thing is that the mindset has changed now.
So, sir, similar questions are there, that will the MCI guidelines change after the COVID? And is HIPA certification required for this? Or whatever,
they have said that you have to do an online course, but I don't think they are still ready to do that online course. So once they do that, I think that should be a kind of a easy thing for all of us to do. But the guidelines are there for good. I don't think they will change because they're reasonably all right. Sorry?
The guidelines are very friendly also.
Yeah.
No, as of now, they are friendly, but when you start having medical legal issues, then they might become more stringent in a non-COVID era.
The medical legal issues, because medical legal issues will either also be there. And Dr. Rajshekar said that it's an excellent opportunity where we can actually call the patient to come over to the clinic. Like, see, even in the post-COVID days, as Mahipal was saying, we need to maintain social distancing. So any practitioner would be seeing much less patients in the clinic. And, this is the new normal that's going to happen for at least God knows what amount of time. So, I mean, this tele thing should be on. I mean, I would feel that most practitioners should seriously start thinking about it.
There's a very
so
interesting question, sir. There's a very interesting question that what's the solution for illiterate rural population?
Yeah, I know. I think we talked about only the people, who are savvy on your laptops. They have email and they have mobile numbers and they have smartphones.
Sudhir wants to say something on that.
I think Rajesh, we are underestimating your Kamwala is or your Dudwala is more. They distribute the dabbas with their smartphones and things like that. So I think let us not underestimate. I think that's what.
Go to Amazon and Flipkart and buy a lot of things.
Yeah. Dr. Sudhir, you were wanting to say something.
So we had, as I said, a few of the cases where we could not get connected with some of the patient when we send an SMS. But we could connect them when we tried calling through an automated calling or through the secretary. And the patient were very happy. They were in villages. They got operated and they have gone back to village. They didn't know what to do. I think we need to look into all options. And since you have EMR in front of you, we have already opened up, still we can connect. So we need to actually look into every option. So going back to post-COVID era, I think we have a greater role of teleconsultations for these kind of patients, because most of them cannot come back because they come to a tertiary care center, get operated, and they go back. But we need to follow them. So like patients with PK or those with long chronic conditions, I think we can have a regular follow-up with them. They will be happy to get connected, and we can also be comfortable with the follow-ups. I think there are a lot of opportunities on teleconsultations.
So questions for three of you. I think Dr. Ritika, Debashish and Sudhir. Some commercial names, etc. I think they were discussed from where all normal members, AIOS members can kind of have this commercially available and also on the cloud for Sudhir. So Dr. Ritika, then Debashish and then Sudhir.
Yeah, of course, with Care Clues, that's one provider that we know of. He was with Practo, he was in a senior position. So we can just connect with me. I have no financial interest. I can connect it with Care Clues, or they can go to their website, careclues.com, right?
Okay. Dr. Ritika?
Ritika, there are a lot of questions for you, and I think Ritika's talk we can.
I can. Okay.
We'll record your talk and upload it when we upload the final video and the audio, so that the audio is clear. So you'll have to do it once again for us. Record it.
A lot of people are wanting to know whether the presentations will be uploaded on the website. So
yes. So Ritika's, we will have it recorded and then upload it again.
So maybe as regards most of the platforms, I think they are regional representatives in all the metros. And if you would like, I can ask the official, the headquarters to share a contact for all AIOS members. I can coordinate that if AIOS would like to. Then at a society level or at a personal level, you are free to engage with them. A lot of them are actually open to associating with an organization or a society and offering, at least during the COVID era, no profit services. So there is a great social awareness among them also, and they're also trying to participate in a proactive manner. Except for Practo, which is already established, where the charges are high. That I think it's better that people connect to personally. All the newer ones are very socially conscious and willing to participate.
Okay. Can I say something?
So
yeah, Dr. Garewal.
Yeah, there was mentioned earlier about what the role the societies can play in a situation like this. I think this is a situation where Dr. Mahipal, the AIOS can have a very, very important role, and that will allay my fears to a great extent. You'll have to see what the logistics and legal issues are. If the AIOS can give a platform which will be very, very easy to make and it is available to all the members, I think that will be really excellent at this time, and it will be a long-term solution.
I think Dr. Praveen Krishna has to leave, and there is one question which has come up for him. Dr. Praveen, people want to know how much do you spend in all the devices that you were showing and that have been incorporated in the LVPI telemedicine in ophthalmology?
Well, all those devices are developed in-house. So I do not know the exact amount of cost that's gone into the development, but the goal is to have them available for use as low-cost devices. So eventually, the goal is to be able to have as many people access them as possible in the future. So whatever the cost will be in the future, we've not thought about that, no, have not set that. It will be very affordable and accessible to the majority of people.
Okay. Thank you, Praveen.
Dr. Rajshekhar, you want to say something? Sudhir, go ahead first.
Yeah.
So going back to the previous question, AOS had like almost 10 years back, there was a technology committee who reviewed all the EMRs one by one, and they put it up in their website, which are the EMRs which they have evaluated and what are the pros and cons of each one of them. Going forward, I would suggest there should be a technology committee who can audit all these platforms which are available, and they can post it on. So I was actually part of the EMR guidelines committee for the government of India, and we had come out with guidelines. Unfortunately, they are not implemented in full swing. I think like NABH, all EMRs has to be audited, like even in US and all, they have to be audited and then be released. Like the consent, medical legal issues, all these are security issues, all that needs to be taken care. So we need to have a committee who can really audit each of them and then come out with some process where we can shortlist some of them.
Yeah, thank you very much, Sudhir. I think you just preempted. I think by the next week, these committees are going to be out, and there is an EMR committee that is very much in going to be in place. Apart from this telemedicine, I had not thought about it that aggressively, but we were looking at an EMR that a normal AIOS member can actually use in their clinics. So I think we can expand the scope onto telemedicine also, and we'll surely put you on the committee, that's for sure. Thank you. And I think Rajshekhar, you wanted to say something?
Sir, here, sir, since it's a new thing, among the colleagues, there has to be a better acceptance of telemedicine. Most of the times, these medical legal issues come because one colleague says, "Oh, was it done on telemedicine? That's why you missed this. That happened like that." That kind of a talk should not happen among ophthalmologists, because we should respect whoever has done that. He has done with the full conscience that what telemedicine could offer and what it could not offer. And another ophthalmologist making a comment can cause a lot of problems. So, and hence there has to be better acceptance and awareness among colleagues.
I guess consent form should have all those things included, that, you know, there are certain limitations, and I mean, it has to be formulated in such a way that in a medical legal issue, the treating physician is saved and is not into that risk.
Yeah, we did circulate a consent form. Maybe we can look at it again from the AIOs did circulate. So we'll look at it again and maybe make it more comprehensive. That's it. Namrata,
I think, sir, we did have a book circulated on the consent forms, and if telemedicine is going to be included, then we should, you know, also put an alternative there, whether it's a teleconsultation or a face-to-face consultation in each of the consent forms.
I guess that can be added to the book, because we had not thought of this kind of a situation.
Okay, I think, should we take it on for another 5-10 minutes or?
I think we can take, and then we would have completed all the questions.
Okay, there's a question, there are a lot of questions on refraction, on vision, etc. So the solution that I have looked at personally, these people that come and shown me, is actually also with the iPhone or with the Android, you can actually also do a refraction. So there is this thing which is pretty much, so they had a prototype, they didn't come back to me, but this is out of the Bay Area in US, that the phone is going to be used as an app, and you can, you have their just small little devices that they want to sell, as I told you, between $100 to $200. And you can check the entire family's refraction, etc. How accurate it is, one, that's the test of time. That's why they wanted to collaborate with us. But then all that I'm trying to say is there is a lot of thought that is happening in this, that you can have home refraction testing that can be done. And I think this is coming mainly from the optical space, even in the US and in India. And vision for the illiterates, etc. You can do anything they have for kids, etc. The pictorials and everything. So I think the days are not far off. I think maybe a couple of months, 1 year, 2 years, that you could get some idea of the refraction as to what the person sees better and not.
Right.
Rajesh, any question? Yeah, Dr. Devashish.
Yeah, one small thing that we do is at the beginning of the year or by the year end, actually we give calendars, we give 1 lakh calendars to our patients. And on the reverse of the calendar, there's a vision chart, the color vision chart and all that. So, I mean, you can also consider this token, which also helps a useful thing, especially, you know, people keep it. So it's a 1-pager, the calendar with
So there is a question for Ritika. Ritika, what is the charge? What are these formal platforms or commercial platforms? How much do they charge for their platforms to be given to the practitioners?
So there is a charge, either if you buy the whole product, that is the most expensive bit. Otherwise, the charge can be per call. Practo charges the highest, about 15% of the consultation fee, or 100 rupees, whichever is maximum, 15% plus GST. And one teleconsult lasts for 15 minutes. The others are looking at sometimes even not charging in the present era, because they've just made the teleconsult module. And there are people who are charging about 2 rupees a minute, or a subscription cost per month of about 1,000 if for a particular volume. 1,000 to 2,500 is the subscription cost, and that gives you certain minutes. So that is the range. It's not a very expensive proposition. The only thing is the reason we should be independent, but you do not get so many calls. Arvind has given in writing that they're getting about 30 calls a day. So after the COVID era, for 10 or 15 calls a day, it becomes difficult to build a very intuitive platform for an individual. So though we should try and be reliant, but these, in good faith, these platforms are at a reasonable cost and can be leveraged.
Okay, there are a couple of questions as regards tele-ophthalmology. Can a patient request that he wants to see only top doctors like Dr. Garewal, Dr. Devashish, and PVK and others? So can would you want to? Can the patient have a deciding this thing, or the patient has to live with the doctor?
Your signature, like it's a good platform for second opinion. It saves your chair time, like
Yeah.
Everything is being worked up. It's like a second opinion kind of a thing, where big names come. So I mean, you can just endorse Dr. Maipal Sachdeva.
Okay, so the other question is that supposing you have to write a medicine, should you write a generic name, or and if the medicine is not available at a particular pharmacy and the patient wants to get back to you, how does the patient get back to you?
Guidelines is clearly written. I mean, the prescription should be in the format that that generic name with a whatever chosen brand name that you want to, the dosage and the times of application, the percentage of that particular generic that has to be put. So
there's one question. Please.
Yeah, go ahead, Rajesh.
There's one question that how to take consent in WhatsApp consultation.
Okay, the thing is that you send this thing. The patient can either put a digital signature, or the patient puts that on paper, maybe writes it by hand and signs it and sends back a WhatsApp. Take a picture of that and send it back to you. So that's how the patient will have to do that. So maybe he writes it down with hand and then sends a picture of that. If the patient has a printer, that's fine.
So WhatsApp has a legal sanctity, because Dr. Ravindra wants to know what is the problem with WhatsApp apart from the fact that the server is in Singapore.
So that's for the business WhatsApp, Dr. Sudhir, you can say, but otherwise it has a legal sanctity. There have been cases that have been filed by people based on what has been written on WhatsApp, and the patient has, it does not as regards the consumer protection, but these are other cases, and there has been a criminal liability that has been fixed on what the person has written on WhatsApp. So that stands in the court of law. So that's not something that it does not have a validity, because the number of the person who has sent it will come. Even the person has his DP, that will also come, and you take a picture and you can put that as evidence in court.
No, there are a couple of questions to Dr. Devashish.
Yeah.
That if the platform sells away your data of your patients, then what?
No. I mean, obviously, when you get into an agreement, it will be a properly formatted agreement. And of course, I think it is better, as Ritika said, to go with there are a lot of startups. So like the one we are trying to work with, Care Clues. So they are small groups and they are good. I mean, they're reliable, they're close. I mean, these are the people we should be working on. It's not very, uh, I mean, what I'm trying to say is a practitioner, cannot afford so many things. It's just that something can be added to your website and it actually connects and does the transactional bit. So that is what you need to.
Do you suggest a proper contract for that?
Oh, there has to be.
Obviously, there has to be an
Yeah.
MOU with everything. So I mean, that is usual. I mean, yes.
There is basically a group of ophthalmologists out of Punjab who are wanting to do this, and they have approached us with their product. I think there will be people who will be coming up, but I think the EMR committee from AIOs will look into this, and we should come out with a recommendation. Dr. Ritika wants to say something.
Yeah, I just wanted to add that since last year, now if you can prove that somebody has stolen your data, it is a jailable offense. So it is now under the pursuit of law. So if you prove it, you can take suitable action. The second thing regarding consent is that even if you don't have a consent form, during your verbal or video conversation, you can read out the consent and the patient can say yes. And that recording can also serve you as a significant significant marker of the consent of the patient. That particularly helps in illiterate patients because it is very difficult to give them a form and then expected to fill it back.
So actually what Dr. Ritika is saying, we did have an incidence of one of the consultants taking away data as regards patient database, etc., from Center of Sight, and obviously we didn't go and file a criminal complaint, but the services were terminated immediately. So this is a legal offense that the privileged data that is there, the data is privileged of the center or the company or of the institution, and nobody can actually go and take away that data. So that's actually a cognizable offense now. Yeah, Dr. Sudhir.
Yeah, just to add on, most of the small companies, when they charge 1,000 rupees, they're all banking on data. So what they generally do is they use an anonymized data and which will be sold to the different companies. So that is because when they sell anonymized data, we do not know from where it has come, who is the patient and all that. So that is still going to be one of the big money earning for these companies, why they charge very less. So we need to be.
So you are right. Even Facebook was there they had a suit on them and they had to kind of settle, and all these big companies were actually selling data, and that is exactly the problem that one has to actually deal with. Dr. Namrata, Rajesh, any questions else? There are lots of them. I haven't gone through the entire list. Any other questions you think?
There's one question that commercial application like Practo do not take consent specific to a doctor or clinic. Anything?
Now, Practo is an aggregator platform, basically Practo promotes you, like it solicits you as a practitioner. So essentially, as Ritika was saying, there people go to Practo and don't go to actually Rajesh Sinha. Here we are talking of a situation where patients would go to Center for Sight or Disha or to Dr. Rajesh Sinha. That is the question here.
So question for you, Dr. Rajesh and Dr. Namrata, when do you think government institutions will think of doing telemedicine and getting onto EMRs?
So I think, sir, at AIMS, we are already, the main AIMS department is already full-fledged into telemedicine, and even ophthalmology is getting into it. And I think most of it, quite a lot of it depends on the EMR thing. So that is still in the mid phase and is not completely developed for RP Center. I think we would be getting into it soon.
And as far as our personal patients are concerned, we are doing WhatsApp. We are giving WhatsApp consultation based on WhatsApp photographs. So that way, a little bit of teleophthalmology we are doing.
Is it a precursor to something, Rajesh? So anyway, I think should we sum it up? I'll just ask all the speakers and the panelists to just give a 30-second or a 45-second summing up. Dr. Praveen, let's start with you. Anything specific, one or two points you wish to highlight again?
Just want to leave with the message that this point of time, telemedicine is not a substitute for an in-clinic visit. I think we need to identify the patients that we can actually see through telemedicine, and probably the best ones will be the ones that you've already seen in the clinic once. And if you can cut down a couple of visits for them to the hospital, that probably will be the best service at this point of time. New patients, I think we need to partner with doctors locally from where the patient is coming from, and refer the patient back to ensure that you get little more data if the patient still wants a consult with you. I think that would be my takeaway.
Thank you. Dr. Sudhir? You're muted, Dr. Sudhir.
Yeah, I'm sorry. I fully agree with Dr. Praveen. I think telemedicine is going to be helping us in a long run for follow-up patients who cannot travel back. And actually, it should be a part of a triage. Most of the patients doesn't know whether they fall into which category, as we are practicing on specialty care. So unnecessarily, they come and get into our clinics. So I think it will be a very good opportunity to triage the patients into different specialties, so then they can take care. And for second opinions, leveraging with the local ophthalmologist and optometrist will be where they can get it initial examinations, upload them, and can help them for more better advice.
Okay, Dr. Devashish?
Yeah, I would see more advantages. You know, it's not that it's a COVID situation which is actually forcing us to go into telemedicine. I mean, of course, it is stimulating us. And I would see its benefit in going to the outreach, in, also putting us in a platform of strength where basically maybe because as Dr. Grewal said, that the Google and the Amazons might be coming. So it is like, it is whose patient first? Is it Center for Sight or Disha's patient, or is it Amazon's patient that will get operated in Center for Sight or Disha? So that's another area. The third area, I would say that, the retina consultants always keep complaining, or the cornea doctors, like 80% or 90% of our patients are follow-up patients, and they don't get new patients, so they can actually, it has the leverage of their free time or their, convenient time to be accommodated, and more follow-ups can be more efficient and more planned by telemedicine. I think that is another opportunity that I see. So, and second opinions, as I was talking of endorsements of Mahipal Sachdev having seen, whereas, you just sign it like kind of. Yeah.
Thank you. Dr. Rajshekhar?
Most of us are doing some form of telemedicine as of now. But here, we are getting it the legal sanctity, and I see a lot of role for the societies, both AIOS and the state societies, to work closely to get a legal framework right, so that nobody gets into any trouble. But there is good scope, and there's a way forward. So we can use it because it's a leveraging of technology. What we are doing is leveraging technology for the benefit of patient as well as the doctor.
And I think you being in Bangalore, that's the Silicon City of India.
Yes,
that's
sir.
going to play a major role, right?
Yes, a lot of players are from this place, sir. Even the Tracto is from this place. But we should focus here on doctor centric, like Dr. Devashish was saying. Many of these players come as pro doctor, but they will be taking away your data and they will be selling it somewhere else. And hence, we need to choose a platform which is doctor centric with good legal framework, so that it's protected.
Okay, Dr. Ritika.
Yeah, my recommendation would be that though we are doing it for a social cause, there are a lot of legal implications, and to refrain from doing things like WhatsApp consultation, and try and, because there is a framework, stick to the framework. We may have an open mind or not an open mind to commercial platforms, but my honest suggestion is just speaking to the founders and seeing how their platform works gives you a great insight on what you are looking to achieve. So you may not adopt their platform, but please do take a demo so that you know what your end objective is and how good you can get at it. And that would be my sincere advice, to take a demo and build it yourself if you want, or just ride on an existing platform.
Dr. Garewal, unmute please, Dr. Garewal.
This is something which finally everyone of us finally will have in some or other forms. But I again say that each one of us has to define what the objective is and what we are going to get out of the telemedicine. Second is that data security is very, very important, and make sure that your data is secure and make sure that you are legally compliant in whatever you do.
Okay, Rajesh.
I always felt that telemedicine is a very good tool for specialties wherein, treatment is done based on reports, like say, for example, endocrinology, etc., wherein it can work as good as, seeing patients in the OPD. But yes, things have evolved in ophthalmology as well, and seeing the platform that Dr. Sudhir mentioned, Dr. Grewal mentioned, Dr. Praveen mentioned, so Dr. Devashish mentioned. So all these platforms, after seeing all these platforms, it appears that things are evolving. And as sir, you were also telling about the refraction apps that are coming up. So all these things will definitely help in, reducing our load as far as our follow-ups is concerned in future, because most of the follow-ups, many of these follow-ups will be shifted to the teleconsultation. And perhaps, COVID has to go. So someday it will definitely go. Then obviously the physical consultation will come. But the follow-ups can be definitely shifted to, teleconsultation, and that will reduce the load on patients, on physicians.
Dr. Namrata?
Sir, I will take up from where Rajesh has, ended, and that is, I do believe it has a great future, but I think with it will come another set of problems which we all should also look into: the data security, the data safety, the professional indemnity, a whole lot of medical legal concerns, and of course our own peer rivalry, etc., etc. Apart from this, I do believe that as far as the small nursing homes, the solo practitioners are concerned, the government hospitals are concerned, that telemedicine still has to, it's still not there where it should be when you compare it with the corporate hospitals and bigger institutions. And when it penetrates into those areas, then, you can really say that it is there.
Okay, I would just wish to say that there are several unexplored areas which would come into play. And one thing which we haven't discussed, I think teleophthalmology might become the standards for conferences in future, but the other thing that what Dr. Devashish was doing was that group consults, etc., could come in a bigger way as to difficult problems being sorted out by having 5-6 experts do telemedicine or a teleophthalmology con call and share the data and come out to the best patient practices. This happens pretty often in oncology, where you have different specialists coming together and doing a meeting to take forward a multi-speciality kind of an approach. The other thing is, I think, which is being taken care of by Arvind, etc., that this could also help in a lot of remote areas where you could have vision assistants, even LVP, where you can have vision assistants, etc., make a funnel for the hospitals to get in patients who need intervention or surgeries, and otherwise just take care of normal day-to-day problems without the patient having to travel long distances to come to maybe 50 miles or 30 miles. So typically when you're looking at a cancer patient, the typical travel distance is about 300 to 400 kilometers that a cancer patient travels. But in ophthalmology, the travel distance is about 15 to 20 kilometers. They don't want to travel more than that. So that is something which is important, that this may change the way the periphery or the people who are in villages, etc., are going to be handled in future. So I think all in all, I think there is a spotlight on teleophthalmology just now, or telemedicine, and it's good that the government has acted, or the MCI has acted very, very proactively in this particular sphere by issuing guidelines, because otherwise it was a gray area with some high court judgments which were very much against and which had prohibited any use of any audio video device for giving consults to patients. So I think I wish to thank all the panelists, all the speakers, and all those members of AIOS who came and joined in. And I think they benefited from it. And please do keep us posted as to what exactly you want in future. I think Dr. Namrata, you have 1 or 2 more webinars planned, which you could kind of tell the people as to what exactly we are planning.
On 14th of April, we have a webinar planned on, whatever the decision of the government is as to how to go about it in different states. I'm sure if it's a staggered lockdown, then it is going to be different for different states. So how to come back and after the COVID, we have a webinar planned on 14th. Then there are webinars which are planned on dry eye and glaucoma, and because we have to break from the Corona times as well. So the information for that would be there on the website as well as in your emails. We would like to thank all the speakers and particularly the President AIOS, Dr. Mahipal Sachdev, for envisioning these activities that we do and for making them happen with positive conclusions and logical answers. And we would also like to thank for this particular webinar Johnson & Johnson, who's always come up without any frills, commercial frills attached to it, and who've helped us in this educational activity, particularly Mr. Jaswinder. I think he's there on the panel, if Mr. Jaswinder can come, and Mr. Gaurav, who is the person who makes these webinars happen logistically, who's the vendor for these webinars. Thank you, Johnson & Johnson, and thank you everybody for being with us today, all the speakers as well as all the people who watched the webinar.
And finally, I'll say stay home, stay safe, and stay healthy. All the very best to all of you. Thank you.
And keep watching the webinars in the period of lockdown.
Okay.
Thank you.
Thank you.
Thank you. Bye.